But it's a great pleasure to introduce Dr. Rick Bold, who doesn't need much of an introduction to this group, or hopefully not many operations either. But he's a true Californian. He went to undergraduate at UC San Diego, medical school at Stanford, did his surgery training at UC Davis East Bay, when the East Bay, the now UCSF East Bay program for years, and started out as a UC Davis affiliated program in the time of the Great Claude Organ, and which is really an amazing gift when one now looks back on, under whose tutelage did you train? Really made some tremendous contributions. Did research time at UT Galveston, as I recall, before doing his surgeon training at MD Anderson. But he's of late, in addition to taking on the responsibilities of being the physician-in-chief of the Cancer Center, has spent significant time learning and thinking about issues of national healthcare delivery. And like I said, I expect you to have all the answers. So look forward to that.
Thank you.
Thanks, Dr. Bold.
I'm going to take off my mask because nobody's close by and I speak a little bit better. So we're all required to do this to set our objectives for this talk. So I hope to give some understanding about what our current condition of financing of healthcare delivery is and why there's impending pressure for reform, to get a basic background about what the history of federal and state healthcare insurance looks like, because that really plays into financing. And then I'm going to touch a little bit on the future considerations of reforming our healthcare coverage. And as I sat in the back of the room, I was looking at my Twitter feed, and the Atul Gawande is going off this morning on where we stand today in anticipation of the presidential debates tonight. So here are my disclaimers. I am not an expert in national healthcare policy. These views are all my own. They don't reflect UC Davis, State of California, Department of Health Services, CMS, Health and Human Services, the Kaiser Family Foundation, CDC, American Hospital Association, the OECD, the Democratic National Party, the Republican National Party, or anybody else you can think of. This is just me. Here's another important part. This lecture is not meant to be political, but it is about politics. The reason it's about politics is because state and federal government decide to a great degree on policy, and it's our elected officials that determine our national health care policy. So with that, I want to put in one plug for an acknowledgement. This is Stuart Altman, who was one of my faculty. He's a healthcare economist at Brandeis. One of his biggest impacts has been he's chaired PROPAC, which is the group that advises CMS. He chaired it for 12 years. He's also chair of the Health Industry Forum. He's been an advisor to 5 presidents from Nixon to Obama on healthcare policy. So I'm going to start with the framework of what health and health care looks like in the United States. This is from the OECD, the Organization for Economic Cooperation and Development. It's an S because it's primarily based out of Europe. It was founded in 1961 to look at a variety of issues internationally in the goal of delivering better policy to guide better human health. Right now, there are 37 countries. They issue a variety of reports. If anybody's interested, you can go to their website, oecd.org. And I'm going to present some data from their 2019 statement on health in the world. So I think everybody knows this. We spend more money on healthcare than any other country in the OECD. Here is the average at about $4,000 per person per year. The U.S. spends slightly over $10,000 per person per year. And there's a significant gap between first and second place. So in this situation, I'm not sure first place is a good place to be. Most of the countries that comprise OECD are developed countries, but we see a smattering of other international countries that give us an idea about healthcare delivery. Unfortunately, that growth in our spending continues to rise and will rise even further. So right now, that per person per year spending is rising as a reflection of our GDP, gross domestic product. And right now, about 18% of our GDP is spent on healthcare delivery. And that's rising. If you look at where we are here and projections of where we are, and I'm going to get to that a little bit later. It's quite staggering, and that's why I'm calling this talk an impending urge for some revision in what we do. If you ignore everything else in my slides, this is the single most important slide, which is what we get out of the money that we're spending. We don't benefit, like other countries, from the expenses of our healthcare delivery system. This is life expectancy graphed by expenditure. Along the x-axis, we have increasing spending, and on the vertical axis, we have increasing life expectancy. So these countries up here spend a fair amount of money, but they get something for that money. They get prolonged longevity. These countries spend little and have poor life expectancy. The US is the only country in this quadrant in which we have the highest spending, but below average life expectancy. This variable along the life expectancy is not subtle. We're talking at least 10 years of difference between the lower levels, Latvia, Mexico, and the higher levels of Japan. And the US is not getting their money, their benefit for their money. This looks at the another category, which is avoidable mortality. These are things like preventable deaths and treatable deaths, encompasses a broad definition in terms of things like trauma and treatment for stroke, heart disease, and other preventative care. Again, spending increasing along the x-axis. Along the y-axis up here is increasing preventable mortality. The US sits here, again, the only country in this quadrant where we have the highest spending, but a pretty average prevention of mortality from preventable diseases. So this is one of the most important things to look at, which is we're not getting the benefit of all of that excess spending. And in fact, things are getting worse. This is life expectancy in two periods, 2002 to 7 in the white circle, 2012 to 17. And you would expect that during that decade, because of improvement in health, we should have seen improvement in life expectancy. Here's the United States. Our life expectancy in that 10-year difference actually declined. We're moving backwards in our expectancy. You would like to see things improve over time. And we didn't. That negative 5% or nearly 5% means life expectancy in the US is worse now than at the beginning of the century. Despite all that, we think we're pretty healthy. So this is looking at those OECD countries and looking at what the population perceives as their health. They're asked to rate their health as good or very good. We also graph it by income. Here's the United States. Nearly 90% of Americans think their health is actually very good, when in fact it's pretty poor. If we look at income status, the highest income status, which is the gray diamond, Americans in the highest income quintile think that our health is excellent, when in fact it's not. The lowest income, you see this dramatic difference. This is the income variable that impacts our perception of health, in which the underserved, the low socioeconomic status, and the ones with poor access have lower health and lower perception of health. So we're not doing very well, but somebody's telling us we're actually pretty good. With that framework of what we're spending and what we're getting out of it, I just want to give one introduction, and this is for a lot of the people entering their career as physicians, about what healthcare looks like in the United States. So there's really two ways you could think about coverage. Either you don't have coverage or you do have coverage. So if you don't have coverage, you're relying on free care, in which you actually have fairly limited services. This is through the emergency room. You can pay for it out of your own pocket, which really means that this is only for catastrophic events. You're not going to go to your PCP for regular healthcare maintenance and pay for out of pocket. Or you choose to receive no care at all. Third-party coverage can be broken down into private insurance and the two governmental payers, Medicare and Medicaid. Depending on how those plans are organized, you can either have access to any healthcare system, which in terms of hospitals and hospital systems can be government systems like the VA, county hospitals, can be private safety net hospitals. Those are decreasing in number, and other private hospitals. UC Davis fits into the governmental hospitals. Or you can have a limited provider. This is things like Kaiser, in which your network of physicians is restricted. Now, what determines good health? There are three main categories of good health. Your personal characteristics, who you are and what you choose. Other social and private factors, this is your socioeconomic status, race, ethnicity, geography, and then the healthcare delivery system, what healthcare services you have access to. So with that broad view of how healthcare is delivered in the United States, I want to dive into the federally supported health insurance plans. So most people understand Medicare and Medicaid. They were enacted through two separate federal legislations in 1965 for Medicaid. It was an amendment to the Social Security Act. 1966, Medicare was implemented under LBJ. Actually, both of these plans had been in the making since FDR coming out of the Great Depression. And we saw Medicaid evolve out of Social Security. President Truman tried this at the end of World War II. And nearly every other president up until LBJ had been trying to work toward this. Medicare covers the elderly. Medicaid covers the low income and disabled. Right now in the United States, Medicare covers 60 million Americans. Medicaid covers 74 million Americans. So between those two federal programs, over 130 million Americans are covered by federal health insurance plans. In 1997, Bill Clinton signed into law the Children's Health Insurance Plan, or CHIP. This was coverage for uninsured children, but from modest income families, in which those families would not be eligible for Medicaid, so the children would not be eligible, but this covered the children. CHIP covers approximately 8 million children in the United States right now. And finally, the Affordable Care Act, or Obamacare, was signed in by President Obama in 2010. The main components of this were the expansion of Medicaid, as well as the individual mandate to require some form of health insurance. That's subsequently been overturned. But in 2016, there were approximately 17 million. With the loss of that individual mandate, people have opted out of enrolling in Obamacare or purchasing health care plans on the exchange. That number's dropped down to about 8.5 million. So between these four plans, 150 million Americans have some form of governmental supported insurance. Nearly half of our American population is covered by governmental plans. Now, this is not universal health care, but this addresses some significant fractions of our population. And this is why I said this talk is about politics, which is our federal government guiding these plans really does impact the health of Americans. Now, this is mostly for the people in the room who think about how we fund this. So Medicare has four structures. Part A covers hospital care. Part A is covered by payroll taxes. So every time you look at your monthly statement and it says Medicare tax, this goes to support the hospitalization of Medicare recipients. Part B is the outpatient care. This is care in the clinic. This is care for laboratory tests. This is actually paid by general revenue, as well as the participants pay a premium for their outpatient care. So two very different funding mechanisms for these major components of Medicare. Part C is Medicare Advantage. This is actually a small fraction of Medicare in which they spun off some of the enrollees to other plans, and the government gave the other plans the money and said, you deal with these Medicare patients. And this is from a combination of what's called the Medicare Trust Fund, which is money put in from the general fund. And then Part D, this is prescription plans. This is also paid for by general revenues, which is federal income taxes, as well as premiums, your co-pays when you go and fill your prescription and you have Medicare. How do we fund Medicare? I gave you those four big buckets. Looking historically in 1966, this is the number of beneficiaries that received Medicare insurance, and you can see this dramatic increase in Medicare eligibility over the last 50 years, in which now we're over 80 million Americans, or will be very soon. In terms of working people, so what I pay for my Medicare taxes to support my mother who has Medicare, when it started, it was nearly 10 working people were paying into Medicare, and Medicare was extremely well funded. As we look at where we are heading towards, we're going to get to probably only 2 people paying their Medicare taxes to support the Medicare enrollee. So with the expenses going up, and you saw that big number of expenses, that $10,000 a year, it's right now only 2 people are funding that. And I'm going to get to why that is a critical number. I already hinted at this. I already told you that the number of people covered by federal sources is expanding. This is a 15-year snapshot in which we look at where people are enrolling in those major tiers of health insurance. Medicare has seen a greater than 50% enrollment. Medicaid has seen almost a 70 or more than 70% enrollment. We look at private insurance. This is what we have through our employer. This is called employer-sponsored insurance, or ESI. Nobody's enrolling in that anymore. We're opting into federal plans, not because we have to. Sorry, not because we want to, but because we have to. We have to because of age, or we have to because of income. And in this Medicaid bucket is actually where Obamacare fits because of the Medicaid expansion. Now, I gave you an idea about the decreasing number of employees who are paying into Medicare. And I told you about the expanding number of Medicare recipients and Medicaid recipients. People have talked about. This is the latest projection in which we will exceed the ability to pay for healthcare through federally funded programs. This is the second most important slide in the talk. So this is Medicare funding over time up to the year 2050, shortly after its beginning in 1970. This is Social Security. Here is Medicaid and the Obamacare expansions. Also, CHIP is in this program. Here's our net interest on our federal loans. This is revenues through federal income taxes and other sorts. In the year 2031, we will not have enough money to pay for these programs. We won't be able to pay for Medicare and Medicaid and the Obamacare subsidies. Now, most people in this room, I think, recognize that we probably won't be able to pay for Social Security, but I don't think many people realize that we won't be able to pay for health care in a decade. Now, we work in a hospital. This is why this is important to us, which is Medicare does not pay us enough to take care of our patients. So this is the operating margin over time based on Medicare enrollees. So in 2000, we had about a 5% operating margin when taking care of Medicare enrollees. That was fine. That was actually fairly comfortable operating margin for a hospital system. This is now the latest data we have from 2016, in which we have a negative 10% operating margin. That means out of every $100 we spend to take care of a Medicare patient, we get $90 back, and we lose 10%. Here at UC Davis, for our financial income statement of 2019 that our CFO was kind enough to share with me, we underfunded Medicare and Medicaid patient care by $100 million. Now, where do we get that $100 million? We subsidize it with private insurance. So this is the increasing reimbursement rate for private insurance. Okay, so this is Blue Cross, Anthem, UHC, WHA, all of the insurance plans that we have. That is subsidizing the Medicare patients. This is the cross-subsidization that we know happens and we rely on. And that's why our hospital leadership really pays attention to what are the contracts for our commercial payers and how much of our patient population are those commercial payers. Because if we don't have this money, we can't take care of these patients. Now, as we rely on those commercial payers more and we increase the amount of money we're asking them to pay for our services, what do? What do you think they do? They pass it on. So this is the increase in premiums for commercial payers matched by inflation and earnings. So let's start here at the bottom. This is nearly 20-year period And this is inflation, so a 47%. So inflation's been running off and on somewhere around 4 to 5%. This is our earnings, average earnings for Americans, slightly better. So Americans over time have done a little bit better in terms of exceeding inflation. These are what the premiums have done. So this is the worker contribution, and this is the overall family premiums. So the commercial payers are just simply passing it on to us. Now, not all gets passed on to us. Some gets passed on to our employer, but we are paying more because Medicare is paying less. What does that mean? This is actual numbers. These are the premiums that you're going to pay for an average commercial plan over that 20-year period. Can you believe 20 years ago, a single person used to pay $2,000 a year for health care? It's less than $100 a month. Now we've seen it up to $6,000 for a family. This is premiums. This is not just out of pocket. This is just what you pay to have health insurance, $18,000. This is your premium for a family. Now, not only have the insurance companies passed on to us the amount of money due to premiums, but they're also passing along our share for the healthcare expense. And they're doing this by changing our deductibles. And I'm not saying this in a bad way. This is how they have to survive. But this is the change in average deductible by firm size over that 20-year period, in which now most people are opting into plans with deductibles over $2,000. So that $2,000 is on top of your premium, but comes out of pocket when you receive health care. So there's two forms in which the commercial payers are passing the money on in terms of the obligation for healthcare expenditures to the employees, patients, and people through higher premiums and higher deductibles. So kind of putting that all together, Medicare and Medicaid are growing, but payments have not grown significantly over that time period and actually underfund the expense of healthcare delivery. With that underfunding, we have shifted cost to private insurance to allow hospitals to stay afloat. And those private insurers are increasingly shifting that cost onto enrollees by premium increases and larger deductibles. Those larger deductibles have been termed skinny plans, in which patients are making decisions about receipt of health care because they have that high deductible and they're opting out. So I didn't show you this, but as those deductibles go up, more people are opting out of it and going to no insurance instead. I'm going to show that data. So this was an interesting editorial from Health Affairs. It's a couple years old, and I think the first two sentences are probably important, and I'll read them. So is increased spending on medical care harmful to the U.S. economy? Good question. The overall share of the GDP spent on medical care is not a problem, provided that the services bought are worth more than they cost. And I already told you at the beginning that they aren't when we compare ourselves to the world. So those high and rising costs expose two overlooked problems, and that comes to waste. Now that waste can be grouped into large buckets, which is misallocated treatment, both over and under treatment, as well as excessive pharmaceutical pricing. And I'll get to that as a major component of our healthcare expense. Also in the United States, we have excessive administrative costs, and I'll show you that. I hinted at this, which is that income inequality and the healthcare delivery, that excessive spending and access to care because we have premiums and we can pay our deductibles actually worsens the inequality in the U.S. by both payer sources and social determinants. So depending on the healthcare plan you have, as well as your social determinants, you get more or less healthcare in the United States. And I think everybody recognizes that, and that's part of our policy issue. And where we look at how we should spend our money, I've used the term health care. It's important to realize health care actually doesn't mean good health. Health care is the delivery of services, usually in the setting of prevention or treatment. But the majority of good health is not derived from health care. When we look at the social determinants of good health in a population, healthcare itself is really a minority contributor to the health of the population. Behaviors are a much bigger component. This is smoking, this is diet, this is exercise, alcohol use. The physical environment, this is things related to environmental consequences. And for right now, it seems like smoke is one of our biggest local physical environment detractors from health. And then socioeconomic factors. Socioeconomic factors and behaviors account for nearly 3/4 of the determinants of good health. Healthcare itself, which is where we are spending our money, actually contributes to the minority of impact for good health. Or shown another way, here's what it looks like across the OECD. So if we break down all of these countries, and this is just about a dozen of them, France, Sweden, Switzerland, Germany. Here's the US. This is the percent of the GDP that is spent on health or on things that would impact good health. The light blue is the amount of money spent on healthcare. The blue is the amount of money spent on social care. These are things that impact the environment, but are not actually healthcare delivery aspects. In every other country, at least 50%, but up to 2/3 of their money is spent on social care. And the minority is actually spent on healthcare delivery. But the US has it backwards. We spend nearly twice as much on healthcare as we do on social care. So we're putting our money in the wrong basket to impact good health. So I told you that's one big bucket in terms of wasteful spending or misallocation of spending. Here's another bucket that contributes to our excessive spending. We spend more money on medicine than anybody else in the world. I told you that there's about $10,000 of per person per year spending. The US average person spends slightly more than $1,200 on medications. This includes prescription, but also over-the-counter. Prescription medications is about $1,000 per American per year. If we look at all these other countries, here's the average in the OECD, half of that number. Okay, we spend money on our medications, that's fine, as long as it actually yields a benefit. Unfortunately, we're spending more and more money as more and more newer medications with higher prices come out on the market. And this is only getting worse. So these are the national trends in terms of where we're spending. I told you the US is right here at $1,000 per person per year. Here's the rest of the country. But if you look at the pace of those curves, our spending on prescription medicines is escalating and contributing to the higher overall and projected spending that we have on healthcare. Again, I would say it would be fine if it contributed to health. I already showed you that we actually don't have the healthiest population in the world, but let's look at it as a reflection of medications. So here's a graph of the drug use per capita among those countries in the OECD versus the life expectancy. So again, if you're treating somebody for their cholesterol, if you're giving them aspirin for their coronary disease, if you're treating their diabetes, patients should be living longer. So if you spend more money, you should get more life longevity. The authors in this paper drew this curve with a lot of these countries up here. The US was not on this graph, so I placed the US on the graph. Here's the US. It's not even on the graph on per person per year spending. I told you it was about $1,000, so we belong out here. Our life expectancy is just shy of 79 years. So all of our excessive spending on medications does not impact our longevity positively. So this would suggest that we're overspending on unnecessary medications if the goal is life expectancy. I'm going to argue that there's probably a threshold. I think the line probably should look like this, in which there is a threshold spending on medications in which you don't get more for the additional medications that would be prescribed. I mean, I see my medication reconciliation list on my patients, and I have to sometimes scroll to 2 and 3 screens and hit reconcile. Patients are on 20, 30 medications. Is that really contributing to longevity? Which I think some of us remember Dr. Holcroft would tell us is the ultimate outcome that we should measure. I hinted, but this is the data that we spend excessively on the administration of our healthcare. So this is the amount of money within the government, both Medicare and Medicaid and CMS, but also an estimate under things like Blue Cross, Blue Shield, Anthem, and the private. How much of their revenue is actually spent on what's called GAO&A, government's administration and office? So the U.S. spends 8% of their overall healthcare just administering the plans, the insurance. And we all know this, the pain we suffer when we have to get authorization and the authorization is denied and we submit more paperwork. So this is money we spend on the hospital getting money. It's money spent by the insurers preventing us from getting the money. This is money spent in the federal government just looking at all the Medicare claims. Here's the rest of the OECD, a mean of 3%. So this is the administrative bloat that has happened that is contributing also. So among the three major buckets of our excessive healthcare expenses, we have wasteful or inappropriate over and underuse, we have pharmacy, and we have general administration. In my view, those are the three biggest things that contribute to our excessive healthcare spending that don't offer us any benefit in terms of prolonged life expectancy or preventable deaths. So this actually summarizes all three of those things in terms of putting it together. So we have excessive costs. Now, don't anybody walk out of this room and share this information too broadly. But here, the U.S. has been criticized for excessive payment to healthcare providers. And we see this politically. We see this through population perception, and it's not true. This is a graph of specialists. I chose specifically because I'm lecturing to surgeons. The earnings for specialists in these countries matched by what the GDP per capita is in each of those countries. So here's the United States. A specialist earns on average 5.8 more than the average per capita based employee. Dr. Farmer took a picture of that. Here's the Netherlands. I might move to the Netherlands and learn how to speak Dutch because I'm going to be compensated well. But we are not out of line for compensation of healthcare providers. This is specialist physicians. As much as you think that some of the other healthcare people are overpaid, nurses, nurse practitioners, it actually matches in line across the U.S. It's not provider excessive compensation that contributes to our healthcare expenditure excess. Now I'm going to shift. I told you this was not a political talk. I told you this was all about politics, though. As we have an election coming up, I'm telling you there is an impending sense of reform that is needed in the United States because of our excessive spending, our lack of appropriate allocation in terms of achieving something that benefits our population. And I told you that it's our federal officials that, to a large part, dictate this policy. They own the insurance of 150 million Americans, so they're going to impact how they do. These are some slides I borrowed from the Henry Kaiser Foundation. This is what Atul Gawande was tweeting this morning. And this is going to give you a little bit of background in terms of where the two candidates stand. Interestingly, healthcare reform is not on tonight's debate topic list. I think it should be, but it's not. So Vice President Biden has actually put out his healthcare plan, and most people are terming it Affordable Care Act 2.0. His statement from his DNC acceptance speech said, "We'll build it," referring to the economy, "back better with a healthcare system that lowers premiums, deductibles, and drug prices by building on the Affordable Care Act." So this is a midway between our current status quo and the options that have been proposed by Bernie Sanders and Elizabeth Warren, which were termed either Medicare for all or a form of universal health care. An interesting component about the Biden plan, it would allow employees to receive coverage on the ACA exchange, even if their employer offers ACA compliant coverage. The details on eligibility have not been provided. What that means is that all of us in the room, even though we have the option of an employer-sponsored insurance plan, we can opt out and go to the exchange if we want it. The Medicare-like public option on the exchange that would serve as a possibility for consumers to receive health care. That's what I'm talking about in terms of us opting out of employer-sponsored insurance plans. would allow us to do that. And so it gives more flexibility for people, not patients, but people, whether they're employed or not, to actually choose their own plan. This would dramatically increase the availability for the public option, in which the Medicaid expansion has not been taken up by the government. So when Obamacare laid out the ACA and defined it, eligibility could be expanded in what's called Medicaid expansion states, and I'll get to that. Those states have expanded the eligibility by changing where enrollment is based on the federal poverty level. Biden has said, though, that this plan is a transition to some form of universal health care, a Medicare for all, single payer in the future. The individual mandate would return. This was eliminated in the 2017 GOP tax bill after the Supreme Court heard arguments. So this means that there's a financial penalty. So if you don't have health care as an employee, you are fined in your income tax. Medicare will further expand by reducing the eligibility to 60 years. It's currently 50. Elizabeth Warren, in her plan, actually reduced it to 50, really increasing essentially eligibility for a majority of American adults. Again, the individuals could access the exchange through opting out of employer-sponsored and going to Medicare. The estimate is that this option will expand Medicare by about another 23 million. So I told you we're already at 80 million. Now we're looking at 100 million Medicare recipients. Surprise billing is something that has taken off, and some people have seen some articles written in the New York Times, San Francisco Chronicle. This is in which there is, quote, accidental treatment by an out-of-network physician. This is usually in the setting of an emergency healthcare condition. So you go to an ER because the hospital's in network, but the doctors staffing the ER are out of network, and you get a bill at their full rate. Okay. New York State is already tackling this, but I think the federal government's probably going to tackle surprise billing and say that if you're out of network and your patient receives care in which any other provider's in network, you'll actually only receive in-network rates. It's a small component, but it's actually really significant, but because this disproportionately affects underinsured patients. This is probably personally, I think, one of the most important parts of his healthcare plan, which is a comprehensive approach to pharmaceutical pricing. I can share some information related to my world, which is cancer. There's a treatment that got approved several years ago in which we administered genetically engineered cells to a patient. This is CAR T. Pricing for that treatment, one treatment, is $2.2 million in order to recover money from the federal government to support the research and development of that, which took decades by that company. So Biden will repeal the existing law that bans Medicare from negotiating lower drug prices with the manufacturers. It's going to limit increases for some of those early to market drugs in which they have been excessive. Is also going to set limits on some of the generic drug pricing, and in which there's a single drug for a single condition, in which some of the launch pricing is really quite exorbitant to cover some of their past expenses. Medicare, particularly recipients, are going to be allowed to buy medications from other countries. I get the emails buying drugs from Canada all the time. That's prevented right now from Medicare and Medicaid recipients, but he will allow that to happen and be reimbursed. He's going to end tax breaks to the drug companies. I think there were quite a few advertisements during this past year's Super Bowl on a variety of drugs. They get tax breaks on that. Biden's plan will eliminate that, and also expand the quality of generics. This is a very sensitive issue, but he will allow undocumented immigrants to buy into the public option, but it would not be subsidized by federal grants. The Affordable Care Act did not allow that to happen. And finally, he would cap consumer spending in the marketplace to 8.5% of their of their income level. And right now that's 10%. So if you earn $60,000, Obamacare said $6,000 could be used to spend in the exchange. This is going to be dropped a little bit more by the Biden plan. The financial impact of that has been evaluated by the Committee for Responsible Federal Budget. There are estimates because of a lot of uncertainties in the plan. I think down here at the bottom is probably the most important aspect, which is I think on average it's estimated to cost us an extra $800 billion. Cost us. So that adds to our healthcare expenses. I'm going to contrast that with President Trump's healthcare plan. His statement from the RNC acceptance meeting was that we will protect Medicare and Social Security. We will always and very strongly protect patients with pre-existing conditions, and that's a pledge for the entire Republican Party. We will end surprise medical billing. We will require price transparency, so this actually sounds a lot like the Biden plan, and further reduce the cost of prescription drugs and health insurance premiums. It sounds quite similar. Interestingly, he didn't call for a repeal of the Affordable Care Act, which he did in the 2016 acceptance speech. With that information, though, he hasn't actually released a healthcare plan. So what I have to guide this presentation is 4 years of presidential record, which primarily is the American Health Care Act of 2017, comprised of two separate components, which is the Senate, which was the Graham-Cassidy-Heller-Johnson Plan, and the House, the Better Care Reconciliation. And then I used his tweets about healthcare. I didn't read all his tweets, I'll tell you. So what is the Graham-Cassidy-Heller-Johnson Plan? This was a Senate amendment from the American Health Care Act of 2017, sponsored by Lindsey Graham and Bill Cassidy. These are all Republicans. What they did is they argued for the repeal of many of the provisions of the Affordable Care Act. And like the overall arching bill of the Better Care Reconciliation Act, which is the House action I'll get to, which was voted down, it would convert Medicaid from an open-ended federal funding to a capped per enrollee allotment to most states. So right now, the federal government hands California money and says, if you have this many people eligible, here's how much money you get. This plan says, we don't care how many are eligible, you just get a set amount of money. If you want to expand your eligibility for whatever reason, each person gets less. If you want to decrease it, each person gets more. And you have to spend that money for certain basic healthcare requirements. Medicaid defines what they have to provide. It's estimated that this would actually decrease the federal subsidy by about $53 billion. This is important because California is a Medicaid expansion state. So the healthcare plan would actually change the concept to what's called block grants. And these block grants, which are set and defined, not based on eligible number of state residents. And the states would have the broad flexibility to use the funds, and they would be able to waive most of the Obamacare insurance rules, such as prohibiting premium adjustment for pre-existing conditions. And most people recognize that in California, those patients on Medicaid absolutely have pre-existing conditions, and this would impact how much they pay, but also would have to match with how much the federal government would get. So in California, this graph here, we're the only blue state. So our funding from the federal government for Medicaid would go down by nearly $80 billion. This is from the American Hospital Association that looks at state by state for the impact of what that bill would have had. We're here listed in California. Because of the change in those premiums and the reduction of our expansion eligibility, there would be 17 million new uninsured Americans, with 3 million in California. Block grants would go down. This is per year. So California would receive $8 billion less per year to take care of our Medicaid patients. That's the Senate action. Here's the House action. This is Paul Ryan, who is Speaker of the House. One of his hallmarks as he moved into the end of his position was really to address healthcare reform under President Trump. He promoted the privatization of Medicare, so taking the federal government and say, let's let a private industry manage it. I already told you that he wanted to move Medicaid funding to a block grant program. Very hard line, wanted to repeal the Affordable Care Act, and that was voted on many, many times in the House and never passed. And he was the primary steward of this American Health Care Act, which is the House action. and the Senate action. That nearly passed. It passed the House but failed the Senate by 1 vote. In the interest of time, I'm just going to move through this. So the House action was termed the Better Care Reconciliation Act. I already talked about the Senate action, and these were fairly aligned. And this would expand the number of people uninsured by reducing the federal amount of money given to the state for Medicaid services. So here is California. Our uninsured amount would go up by nearly 140%. He's given us a little bit of information, when I say he, I'm sorry, President Trump, in the 2021 budget. There's a $850 billion placeholder for this concept called Vision for Health Reform. It describes a variety of things, but nothing with any tangible information. It said it will protect the most vulnerable, especially those with pre-existing conditions, and provide affordability, choice, and control, and high-quality care that Americans deserve. Most people think that this would come from cuts to Medicaid and the transition to block grants under the Obamacare subsidies. It would also directly reduce Medicare and Medicaid costs. This would be, I think importantly for us, it would remove payments for medical residents, so graduate medical education would decrease. Uncompensated care would no longer be paid to the degree that it is, in which we as UC Davis receive additional money because we care for a disproportionate share of underserved or underfunded patients. This is the pharmaceutical savings of $135 billion to Part D. That's the pharmaceutical part of Medicare through the use of generics. And then there is a part in there in terms of medical malpractice reform that he implies would save $40 billion from the healthcare industry in general. This is not a political analysis. This is the Committee for the Responsible Federal Budget that did this analysis. The Kaiser Family Foundation put this out several weeks ago in terms of directly comparing those. And I said these two sound fairly alike in terms of prescription drug. Both of them really want to cap out-of-pocket costs for Part D or Medicare recipients paying for drugs. They'd like to really expand options. And there's some of this information related to pharmaceutical companies and pharmacies. So most pharmaceutical companies distribute through secondary pharmacies in terms of tax breaks that they get as well as rebates. So their pharmaceutical drug plans are actually fairly similar in terms of addressing some of the big components. If anybody's interested, you can go to the Kaiser Family Foundation and see an item-by-item list of where the presidential candidates' plans differ. Now, I told you I'm going to end up the talk with a call to arms. Why I think this is important in 2020. I think adding on to this layer of healthcare expenses that's growing and will exceed our federal government's ability to pay for Medicare, Medicaid, CHIP, and Obamacare. Why there is increasing need for this, but there's not increasing outcome that's matched with those expenses. We're going to overlay the COVID-19 pandemic and the recession and forecasts with that. 30 million Americans have filed for unemployment in the first 6 weeks of the COVID pandemic. And it's likely that we'll end this year at an unemployment rate of between 15 to 20%. And you recognize as you lose your job, you'll lose options for health insurance through your employer-sponsored plan. And your only other option at that point is a federal plan, either through Obamacare or through Medicaid. These are the top highest uninsured states in the United States. Hawaii, because of the high dependence on tourism. California is right here, number 2. We're going to land somewhere around 15% unemployment at the end of this year, in which we're going to shift now the healthcare costs from employees, because they're paid, employers, because they pay part of the insurance plan, now to the federal government through Medicaid or Obamacare. What does that mean in terms of overall financial impact? This is an estimate in terms of the change in unemployment. Initially, they thought unemployment would hit around 25%. It's probably going to end up in the 15% So there's going to be a decline in 17 million Americans who receive their insurance through their employer. We're going to add on 8 million to Medicaid, 4 million to purchasing through Obamacare, through the healthcare exchange, leaving 5 million Americans additionally uninsured. In the expansion states, that's us. That is disproportionately lower because those people can be eligible for marketplace purchases. So this is those numbers just in a little bit different format. So if we look overall, what happens to those employees when they lose their health care through their employer? Almost 30% are going to remain uninsured. And we don't have an individual mandate, so there's no requirement for them to obtain insurance. So these will be showing up in the emergency room for the healthcare in which we absorb the expense. 25% are going to go to the healthcare exchange for an Obamacare-like plan, and then nearly half are going to be enrolled in Medicaid. And Mitch Murray's shop has actually expanded the personnel so that we can help get these people into Medicaid, because some reimbursement for us on healthcare delivery from Medicaid is better than no reimbursement. So I've ended right on time talking about healthcare policy, and I think why 2020 has to be this call to arms for reform, because the cost of healthcare delivery in the U.S. is increasing and not adding significantly to the overall health of Americans. The federally supported plans are unlikely to cover expenses in the near future, and private plans are shifting more and more of their cost onto employees. The COVID pandemic and increasing unemployment is significantly burdening our system, and our 2020 election is likely going to shape our healthcare policy for the next short term into that intermediate term ability to care for Americans. Thank you.
So, Rick, fabulous overview of the sort of impending situation we're in. And if I think back in history a little bit, it makes me wonder how this compared to the Great Depression, when similarly, and who knows what healthcare was like going into that. I honestly don't remember life before Medicare. But it does think that the juxtaposition of the extraordinary cost and the increase in uninsured is really going to force a crisis in healthcare that will mandate change like we've never seen before. Yeah. We've been talking about it, on and off for the last 20 years, the way I think about it. But there was never the burning platform that really made it happen. And you really made a great case for the burning platform is like right at Napa.
Yeah. So before Medicare, in the early 60s, the majority of healthcare expenses were paid by individuals. There was really very little healthcare insurance, even employee-sponsored insurance. Most people forget that the major insurance in terms of employer-sponsored plans came about with the Henry Kaiser Aluminum Company, in which he said, if you work for us, we're going to give you a benefit and pay for part of your care. So the majority of care was paid by individuals. Now, backing up even further, the Great Depression, in which there was no disposable income because of the Depression to pay for health care. That's why FDR actually advocated at that time for a Medicaid-like program. But because healthcare is much more expensive, bills that were generated. I actually have a hospital bill. When I went to the emergency room as a kid, I got a laceration and went to the emergency room when I was 13 and got a bill. This is in the mid to late 1960s. The whole ER visit was $133. And my parents wrote a check, sent it to the hospital, and that was it. And the expense of healthcare delivery has overwhelmed the individual, and that's what's really forced us into healthcare insurance, which historically had been focused on catastrophic things. But now it's for healthcare maintenance, in which the proportion of healthcare expenses that the individual pays is actually the vast minority. It's paid for by insurance and the federal government. But now we're looking at that time in which they can't pay it anymore.
That's Coconut. That's the top. Can you grab the microphone there? Yeah. Right next to you.
Excellent talk. Because from my understanding, there is a case coming before the Supreme Court that may actually reverse the ACA. How would that affect all of this?
So there's two parts to that answer. And the first part is that the House has repeatedly voted to overturn the Affordable Care Act and has never been able to. There's been a variety of petitions to the Supreme Court to hear a case, and the Supreme Court has turned down every petition. When I mentioned the Supreme Court overturning the individual mandate, that was the Texas Supreme Court, and that was requested to go to the federal Supreme Court, and the U.S. federal Supreme Court turned it down. It is highly likely that another petition, or many more, will be submitted to the Supreme Court. Right now, we only have 8 Supreme Court justices, and it's unlikely at 8 justices they will take up that vote, and so they're likely to turn down an action to hear the repeal of Obamacare, the Affordable Care Act, until the Supreme Court is filled. At which point, then they will have the potential for a 5-4 vote, and it's likely, depending on what party has a majority in both the Senate and the House, that it will be petitioned again and go back to the U.S. Supreme Court. So those are my 2 parts, which is they're going to turn it down until they get a majority, but when they get a majority, it will depend on what the political party that has a majority in each of our 2 branches is. And when I said branches, I intentionally meant the presidential branch and our congressional branch.
Rick, I want to congratulate you on an outstanding talk and a terrific summary, and just take the advantage of to emphasize that oftentimes we don't talk about money in our residencies and our education and during our training, and to me this covered all of that education in one short hour. So I really want to thank you for covering that very important base in surgical education. So thanks, Rick.
Dr. Perosi, and we'll bring it to an end there.
It was a great talk. I'd like to echo what Jerry just said. Hard topic to cover, and you covered a lot of ground. I just wanted to comment saying, I feel like we've been watching a train wreck happening for all of our careers. And, we've been talking about this since I was a kid, and we've all seen this coming. And there's, before I get to the final point, I'd like to mention that there's a funny juxtaposition of sort of cognitive dissonance being a care provider in this system, because we're all really freaking lucky. We are so lucky. But more importantly, we're all sort of complicit in this game that we play of, trying to change our payer mix, or trying to create bed space to make our system work better. And there's an interesting sort of self-reflection about this, and sort of understanding, well, I'm playing this game. But finally, I just wanted to say, I surely hope that this moment in time, this crystalline moment in time, the combination of COVID, our sort of economic problems in this country, and this particular election, makes a sort of a call to arms for our American populace to change our culture and our vision on this, because really we're burning so much money on the wrong stuff. It's like the people that spend all their money on cars and fancy clothes and forget to save money to fix your water heater, to pay for your kids' education. I don't know what's gonna change that in this country. I hope that this is the moment.
I don't think there was a question in there. So I will say I absolutely agree, and thank you for listening, and thank you for advocating. And you're right, which is when you say we're complicit, we focus on our microcosm of the hospital, our patients, and our own personal environment in the profession. And I think you're recognizing it, and Dr. Farmer said, this is something that's been talked about for 20 years, and that cataclysmic cliff is now within our sight.
I just want to relate this back to our presentation at M&M this morning. So it was particularly poignant around burns, but also relevant a little bit to plastics. We spend a lot of money, and we have seen the enormous, you talk about the expansion of administrators. And this is not a personal attack on any one part of the process, but because there was money attached to improving your HCAP scores, we expanded our quality organization tremendously to deal with these HCAP scores. But if you ask what really, it's completely ridiculous with respect to the burn stuff. I mean, it makes no sense to talk about quality in burns and cost without talking about size of burns, without, to sort of apply this broad thing makes no sense in terms of what's real quality. I've talked about this before. You can have no surgical site infections, but if you're going to end up with a lifetime colostomy as opposed to a sphincter-sparing operation, you're not getting quality care.
Right.
So we play the game, as you mentioned. We follow the money, and we throw more money to get a little bit of money back, but we haven't really improved quality. This system is completely out of whack.
Yep.
Not providing health care. So please solve this problem. We let you get your fancy degree, so please, we expect a return on investment. Thank you, Dr. Bold. We look forward to the outcome.